All right, hey everyone, welcome to Noon Conference. This is two cases today that I had when I was a resident. One is an outpatient case, one of them is very much an inpatient case. And the title of the conference is Down and Out, which will make more sense as we go. So we're going to start on the left with the chalk outline of a person. Levi asked if this person was FDOC, found down on Colfax. They were not. They were found down inside of a house off of Colfax. This person is this is a 38-year-old woman. She's brought in by ambulance from home where her boyfriend found her unresponsive. Per EMS, the patient's boyfriend states she had a history of heroin and meth use. For EMS, upon arrival, she was unresponsive with agonal breathing. They gave her 1 milligram of IV Narcan. She had an initial pressure of 50 over palp. For those that are wondering, 50 over palp means that if you inflated the cuff on someone's arm and you're deflating it whenever you feel their pulse for the first time, that is 50 over palp. So 50 over palp for EMS. She had a tonic-clonic seizure, they think. They gave her 2.5 of IV Versed and brought her to the hospital. She had an airway by this point as well, placed by EMS. All right. Any questions about the EMS history? Great. She sort of responded to the Narcan, but not a whole lot. So her first HPI here, and again, this is all you're going to get. So 37-year-old woman with heroin and crystal meth use brought in by as a code 10 with opioid overdose. They sort of give the exact same history. They said she initially had some pinpoint pupils. And that's it. So I've basically given you the same history twice. Her vital signs, blood pressure was 110 over 70. Heart rate is 133. For the ED doctors, they get some vitals. And here are her initial ED vital signs, which are sort of going to be her vital signs for the first 12 hours when I was taking care of her. So she's not hypotensive, 108 over 80. She has a heart rate of 103. Respiratory rate is fast. She is breathing on her own on the vent at this point, setting 100%, and she is 35 degrees Celsius, and her weight is normal for her age.
Did EMS recruit?
Great question. Yeah, EMS started a liter of NS, and I think at this point, like only 250 of it got in.
The 28 respiratory rate for her.
28 was her. So 28 respiratory was her. She's connected to the vent, but I think she's 40% FiO2 and like pressure support at this point. All right. Yeah, great. So Peter asked, was there paraphernalia at the scene? So no paraphernalia at the scene. She was basically just found in the middle of her living room by her boyfriend. And the boyfriend said that he left for work in the morning at 6 a.m. and that was the last time anyone had seen her. So truly unknown downtime, but at this point that was 16 hours ago.
It looks like it is November.
So this was, yes, this was November. And so it was cold outside. I believe it was in the 30s or 40s that day. And the boyfriend did say that the heat was not on in the apartment.
Did she have any other like pill bottles or like prescriptions?
Yeah, great. No other pill bottles, no meds. She was basically laying alone in the apartment. And then you look at her history and she really has like no past medical history, but she is from Iowa. And so we don't really have any records. The Iowa is not a reflection on what's happening here. But we got no past medical history and she's got no meds. So what I want you guys to do, seniors, you guys have admitted a lot of these people. You guys admitted a lot of these people in your residency. So take about 30 seconds and pretend you're the ED doctor. You're going to get your normal labs, right? But tell me what other labs you want to get for someone who's found down. All right, let's come back. Some good thoughts. So this table, what did you guys think? What additional labs do you want to get besides your normal, CBC, CMP?
Tox screen.
Okay, tox screen, great.
CPK.
CPK, why do you want to get a CPK?
See, we don't know how long he's been down.
Great. So like quantifying how long she's been down with the CPK. Awesome. Rest of the room, what else do you guys want to get? Lactate, perfect. What else? Glucose. I think that's a good place to start. Cultures, all the good stuff. So here is her urine drug screen, first of all. So she is positive for amphetamines. She's positive for benzos. This is, we presume this was pre-EMS as well, based on some later history. And then she's positive for opiates as well. No cocaine, no methadone. And then her labs come back, and we added on everything that you guys asked for. And her labs are right here. So for the students in the room, the vertical fishbone is how I write my LFTs. The AST is 103, the ALT is 69, the ALK-Phos is 85. So take about a minute at your table to take in these labs, and then I want you guys to give me your thoughts about this.
So
yes.
Most of the like meth in Denver has like a lot of opioids in it. So if they said it's meth, they could have like opioids.
Awesome. So Graham telling us that meth in Denver has opiates in it. So that's concerning. Cool. So take about 30 seconds at your table and give me your thoughts on these labs. All right, some good conversation. I won't call on Jackie because I just heard her thoughts. They're excellent. They're all correct. Jake and Evan, you guys are going to be, Jake, you're going to be at Denver Health in September, admitting people overnight by yourself. So give me your thoughts on these labs.
I mean, I don't have anything particularly surprising here. The things that would like jump out to me as like emergent problems would really be that creatinine bump and hyperkalemia, and everything else could be reactive. I don't really think we need to like worry about that white count really until like we have like a unless we have an infectious source. So I think the big thing for this person would be getting that K down, however you want to do it, and then giving this person fluids as well, and making sure they have a full in more than anything else.
Awesome. I like it. Jackie, can you just tell me what you were saying about the LFTs real quick?
Yeah, so what I was saying is my first concern before I self-labs is that she might have shocked liver because she was hypotensive when she was found, but you would expect a much larger elevation in LFT, so it's probably not that. The other thing I was considering is that she's positive for other drugs. She might be over drinking alcohol, and you don't have quite the 2-to-1 ratio there, but it's close. But given the elevations, they're like kind of mild elevations, so it really could be anything at this point. Most likely it's from toxins, given what the information we have so far, but it could also be like anything in your normal hepatitis.
The isolated AST bump is classic for rhabdo. It's a muscle breakdown. So you'll see that like I had a patient come into the ER at Rose and they just had an isolated AST and then we checked the CPK positive.
Yeah.
You're looking for some cardiac injury too.
Yeah.
Tropes rising a little bit.
So I presume that's just the rhabdo muscle breakdown.
Awesome.
Also with the blood gas, so the pH was plus 0.04 for BQ, but with the correction factor for PCO2, if you would like reduce that to normal, it'd be I think 1.08 for every 10. So it'd still be a little acidotic potentially around the borderline, so it's like a metabolic acidosis too.
Could have a lactate.
Yeah. that's what all of it is.
Nice. That was a very complete. Nice job, everyone. That was actually very impressive. That was a much better job than I did when I was admitting this person at 12 a.m. So all of this happens before you're called at Denver Health. And the question right now is, does this person have rhabdo? Yes. Okay, great. So you think this person has rhabdo. The ED is going to start treating her for rhabdo, and then the ED also gives her things to shift her potassium, which we're not going to go into too much detail here. And they call you and say, hey, we shifted this person. Repeat labs are pending. They're on their way up to the MICU, intubated for airway protection with rhabdo.
Did she get calcium too?
She did get calcium. Yeah, so she gets calcium, she gets some insulin, she gets some dextrose, and she is literally being rolled up to the UCH or the DH MICU when her repeat BMP comes back. I'll show her EKG real quick. This is her initial EKG. This is why they gave her calcium, that she had some peak T waves. Any questions about this EKG? Not a diagnostic mystery once you know what that potassium is. All right, so she is rolling up to the DH MICU. You are looking into her notes, hoping there's something in Care Everywhere when this repeat BMP comes back. So just to remind what the last one looked like, the K was 6.2. So the K went from 6.2 to 7.3. The bicarb stayed stable, but the creatinine got better with fluids. And the lactate stayed stable at 4.2. At this point, her blood pressure is 110/80. So what I want you guys to do at your tables, because this was sort of the diagnostic issue here, is I want you guys to take about a minute and tell me how on earth a potassium could go up while the creatinine gets better. And how are you going to focus your exam and sort of your subsequent workup as she rolls into her ICU room? All right, Jack and Sophie, you guys were having a good discussion over there within earshot of me, most importantly. How are you guys thinking through a creatinine that got better with a potassium that got worse? Hey guys, hey, heads up. We're coming back just so I can hear, because my hearing is not great. Okay, continue, Jack.
I don't think we came to a conclusion as to why the creatinine got better while the creatinine got worse. I think that both creatinine and potassium, not to go out of the rhabdo because of muscle breakdown.
Okay, so
Shifted the potassium. The only thing I could think was hemolysis of the two.
So muscle breakdown, hemolysis. Let me hear it, Anita.
The only other thing we were talking about, I think hemolysis is definitely not differential. Well, she was hyperventilating and blowing off a lot of that like CO2, and now we have she's ventilated and she no longer has that intense response. I do wonder if she becomes significantly more acidotic and is no longer able to kind of intracellularly absorb her potassium, and it's becoming more.
So it's like there's more shifting from like this area.
Yeah. So I wonder if the fact that we are now ventilating her is part of it.
Dr. Gergen, what's her urine output?
Yeah, great question. So they put a Foley in, the UA is pending, but she had 250 out with the Foley in the ED like 20 minutes before. Why do you ask, Levi?
Because if you have 0 cc's of urine output, your GFR is 0. And I don't care what your creatinine is, but if you can't get rid of your urine, it doesn't work.
Awesome. So you're like basically saying like, does it matter? Did we pull out like old urine and her creatinine functionally hasn't changed, but she's just getting worse, so her potassium's going up? I like that. So muscle breakdown hemolysis, is she more acidotic? That's a great thought. And then does it matter, Levi's saying, which we'll sort of existentially address. Would anyone change their physical exam for this person or do anything more on their physical exam than they usually would?
You look for like some like compartment syndrome, where you have like an injury or crush injury or something that's like now being released. You know, these people get found under an avalanche and you uncover them and they get potassium everywhere.
Yeah, Graham, what would that look like if you were theoretically looking for someone with a compartment syndrome?
So like a pulseless extremity or
I like it. So you walk into the room, and this is what her left leg looks like. So the left leg is the one that is more mottled. The right leg is the one that is sort of more her normal skin color. You can see her toes are mottled. And then if you zoom into this image right here, I initially thought that was an iodine swab. That is not an old iodine swab. That is the part of her leg that was dependent. And so when you lifted it up, she had this dependent erythema that did not go away. So we presumed that that was the part of the leg that was resting on the ground. Great, so the leg is cold. And Sophie, what else do you want to know about this leg right now? Great, so the leg does not have a pulse. The leg is cold and it looks diffusely mottled basically across all aspects of it. All right, so again, this probably should be like one of those like type 1 reasoning things where you should know this pretty quickly, but 30 seconds, tell me who you want to consult at 1 a.m. and how you're going to convince them to come to the bedside as fast as possible. All right, who do you guys want to call? I heard people talking. There's 3 options. One of them is more correct than the others, and the other 2 will tell you to call the one. Tax tells you to call someone else. Tax says we don't know how to use the thing you want us to use. Ortho, great. So you should call Ortho. And what is your clinical question for Ortho here?
Please come do a bedside.
Great.
I'm asking you to cut on my patient. Please come do so quickly.
Great. And then just so we're all on the same page, what is the disease process or diagnosis that you are putting on here to tell them? Clinical question is what? Do they have compartment syndrome? Great. So compartment syndrome. We don't see a ton of compartment syndrome in medicine for good reason. So it's an increased pressure that compromises circulation and function of your muscle. So on the left there are the compartments of the leg, which I did not remember until this morning. But there are 4. There's an anterior, a lateral, and a deep posterior, and a superficial posterior. So symptoms, you guys all knew these. It's pain out of proportion, paresthesias, pulselessness, and a tense or firm extremity. But none of those things are actually sensitive or specific. They're just what we learn. And so you actually have to have a pretty high degree of suspicion, and you need an actual method of diagnosis. So what is that method? Does anyone know how they will diagnose this? Yeah, so the Stryker company makes this thing right here. It's got a syringe with some saline in it. And essentially, it injects saline into the muscle compartment and it measures the return pressure to tell you whether or not the person has an elevated compartment pressure. So does anyone know what an elevated compartment pressure actually is? More than 2, great. Throwing a number out there. Not correct, but I like it. 10, okay. 40. All right, I like it. So one of our podiatry residents said 40. 40 is a good guess, the best guess we've heard yet. So the way to think about it is you want to basically go for the delta. And so that's your diastolic minus your compartment pressure. And if that number is greater than 30, you're basically considered to have compartment syndrome. Because if your diastolic is the same as your compartment pressure, you're not perfusing and you're ischemic. And so that's within that range of 30 is when you're not perfusing and you're compromising the muscle. So this person, right, if we go back to her initial vital sign, her diastolic blood pressure was 80. And so anyone want to take a guess what this lady's compartment pressures were? 90, 100, all good guesses. Oh, sorry, less than 30. Yeah, great pickup. Yeah. If this number is less than 30. Yeah, sorry, it's the end of the year. We're all forgetting how science works. So these were her needle pressures. Her anterior was 60, lateral was 76, superficial posterior was 66, and her deep posterior was 72. And so this lady had compartment syndrome, and she was taken to the OR for a 4-compartment fasciotomy. So the OR op note does a very nice job of explaining this, but basically she had appeared necrotic tissue in her deep posterior compartment and her superficial posterior compartment. So that area that was red on her physical exam was necrotic. And then they try to excite it with Bovie cautery to basically see if you can stimulate the muscle. And her muscle did not stimulate in certain compartments. So she returned to the DH MICU at 4:30 in the morning with a new skin finding, which made me uncomfortable. So she returns with 4 wound vacs in all compartments. And you'll notice her toes are still mottled and still quite unwell. But this lady had 2 compartments, so 2 of her 4 leg compartments. She had necrotic muscle and compartment syndrome from being found down. So what I want you guys to do now, take about a minute, and I want you guys to tell me, give me your diagnosis for rhabdo and compartment syndrome. So we can think about them together because functionally the same thing has caused both. And give me some big causes for that. And we'll finish off this first case by talking about rhabdo. All right, so what causes rhabdo? Who wants to just throw out some rhabdo causes here? Crush injury, perfect. What else causes rhabdo, or is it just crush injury?
Drugs.
Drugs, what drugs?
Like every illicit drug ever.
Every illicit drug,
Yeah.
great.
Or I think withdrawal, honestly, like there's a weird drug withdrawal that could idiopathically cause rhabdo.
Okay, interesting.
You have a seizure.
Seizures? What else?
CrossFit.
CrossFit. So if we're gonna put something less diminutive to CrossFit, strenuous exercise, we'll call it.
You get post-calf, the cholesterol and blood.
Great question. I don't know. So you guys were hitting the ones that I had on here. So trauma, that one's pretty self-explanatory. Exertion, this is where Graham said CrossFit. This is also just any strenuous exercise will do this. Muscle hypoxia is the big one. So if you are just immobile for a long period of time, or if you are found down, or if you are in the crush injury, that's how you get hypoxia. Basically, there's a compression and you can't perfuse. Temperature, that's going to be low or high. So hyper or hypo will do this. If you notice the theme here, all of these things sort of go together. Like, right, football players in Texas doing too much strenuous exercise in 104 degrees is not great. Drugs and toxins. What's a big outpatient medicine that we need to worry about? Awesome. So statins do it, cocaine does it, and then like Jake said, just drugs with the capital D will do this. Infections, flu's been known to do this, and then EBV has been known to do this as well. So in this person's case, what happens when your muscle actually breaks down? What does the muscle release into your circulation? Awesome. So myoglobin is the one that's going to cause your kidney injury. What else? AST, perfect. Troponin, if it's the heart muscle, your skeletal muscle should not have troponin in it.
There's small ones that are at the tips of your act.
So this is where the CK comes from as well. And then Jackie was asking me this, so potassium as well. So if your muscle is dying, you're essentially like self-infusing yourself with potassium, depending on the amount of muscle that's dying. So of those things, right, myoglobin becomes super problematic because myoglobin is going to go to our kidneys and precipitate and cause an AKI. So myoglobin, right, will go to your kidney, precipitate with that TAM horsepower protein, and will cause you to have an acute ischemic and obstructive injury, and will give you a Foley bag that looks like that. So this was this woman's Foley bag. And so when you looked at it and you saw her exam, it was pretty clear she was like in the depths of rhabdo. Is there any way that we can like, sort of think about rhabdo, people who have it, who might be higher risk, who might be lower risk? So anyone know of a scoring system? That's a very leading question before I tell you a scoring system. So there is a scoring system. It is called the McMahon score. And I started using it when I was a third-year resident after this case, thanks to Renal's help. So this was the study in JAMA in 2013, where they basically looked at variables associated with rhabdo and created a score. Those scores are on the left there. So age, female sex, if your creatinine is higher, if your calcium is lower, so calcium deposits in injured muscle, which makes it lower, your CPK is higher, or your phosphate is higher, because phosphate's also released from dying muscle. And if it's greater than 6, you're pretty high risk, or it's very sensitive for identifying someone needing RRT. If it's greater than 10, you're higher risk for death or renal replacement therapy. And notably, only a CK greater than 40,000 on here is independently associated. So all the other measures don't really help you as a single objective piece, but together it's very helpful. So this lady's McMahon score, if you ended up doing it, put her in the 11 category. So renal was pretty suspicious early on that she was going to need renal replacement therapy. Graham.
Did her CK go up after you released her compartments? I feel like her CK of 9,000 is actually pretty low for how sick she is. I'm wondering if the muscle breakdown is just not getting back to her system.
Yeah, so her CK went to 188,000 after it went from 9,000 to recheck to 188,000 3 hours later. And so that's a great point by Graham that her CK actually probably wasn't getting out of the compartment as well, because there was so much pressure. And the second they released the pressure and relieved it, it peaked.
Most rhabdo, you're seeing like 15,000, 20,000. Like for how sick she was, it's not that high.
Yeah, exactly. So not super high, which was very surprising. But then I think the next CK sort of confirmed what we all thought should have been happening initially.
What happened to her renal function?
Great question. So she ended up on renal replacement therapy by day 3 because she stopped making urine ultimately. And she was on intermittent HD when she was discharged 20 days later from Denver Health. And then she's been lost to follow-up because I think she moved back to wherever she was previously from. Great question, Levi. A wonderful segue. So not only did she see orthopedics while hospitalized, she also saw plastics. So she had a skin graft of the largest fasciotomy site. This is apparently well healed according to the plastic surgery now. So yikes. But she had a skin graft during the second week of her hospital stay and was healing well when she left. All right. Any questions about acute compartment syndrome from being found down? We ultimately thought it was probably a drug overdose, and then she was just down for so long that she got compartment syndrome. But we have no idea. There never ended up being a way for us to get any more history. All right, so that was down, found down near Colfax. Next one is out in this down and out conference. So the chief complaint here, this is a VA primary care clinic patient I had. His chief complaint was I keep getting thrown out at first base. So this is his initial HPI for me. He said he had lower extremity bilateral calf cramping, which is worse with ambulation. So he said his calves were on fire and they felt rock hard. He said, I can walk, but it's very painful. The pain subsides with rest. He's been able to play softball. He tries to play through the pain, but he said ultimately he was now being the catcher on his softball team because he wasn't able to actually make plays in the field. He was routinely not getting to first base on what he said previously were things I can run out. He is in his late 40s, early 50s. Great question. He has never smoked in his life, going as far back as his military service. Victor, why'd you ask that? Great. And so what would you do to work up his claudication? Little ABI action. Great. So here are his ABIs. This was about the first year I met him for the residence room. Normal or abnormal? Normal. These are normal ABIs. So thankfully, Dr. Waldo interpreted these for me as well. And Dr. Waldo told me that these were indeed normal ABIs. So at this point, I was like, I have absolutely no idea what's going on with this man, but he does not have claudication. So I told him to come back in 4 months because I was like, maybe it'll just go away in 4 months. And it did not go away in 4 months. So in 4 months, I kept saying he had claudication symptoms. And he basically gave the exact same story. He said he tries to stay active, but he gets excruciating pain in both calves after extended exercise. And the pain always resolves with rest. ABIs at this point had been completed, and those are the ones above. So what you guys do now is take about a minute at your tables and give me your differential for what else could be causing claudication symptoms in this gentleman. It's a good question. So it sounds like you want some labs. Labs will be obtained as well. All right, what's on your guys' differential for ongoing claudication symptoms that are not vascular, or at least the ABIs tell us they're not vascular?
When they were worried about, I don't know if this is real or not, but like, yeah, there's a thing like the Reach syndrome, which is like aoroiliac atherosclerotic disease. It's like, I don't know if you have abnormal ABIs with that, but you would have claudication symptoms.
I don't know how to spell that first word, but great thought.
I mean, it's not textbook for neuroclaudication, but I think it's also reasonable to consider.
Awesome. Neuroclaudication. Hyperviscosity. Myositis. Inborn errors of metabolism. So you're thinking he's gone a whole year without talking about an inborn error of metabolism. Is this the day? Could this be the day to talk about an inborn error of metabolism? So what do you guys want to do to work this up further? All right, labs and med review. So we'll get the labs first. Here are his labs. So again, his AST is 76, his ALT is 108, his CK is 1234, which is his baseline creatinine is it's like 0.9, I believe. All right, does this help us at all?
Yeah.
What does it point towards, or what do you guys think we do with these labs now? It's a muscle issue. Great. So is it a myositis? Could be. All right. And then before I show you his labs, I think you guys all know where this is going, unless I'm pulling a fake out here. What med is he probably going to be on? Oh my God, he's not on a statin. Oh my God. So he was not on a statin. So I was so sure at this point, I was like, maybe I've just never seen the statin. No, he wasn't on a statin. He is. He had some. To Levi's credit, he is on a very good allergy regimen. Fun fact: it's very hard to get an allergy consult at the VA. It's a referral, and so this is all my doing. By the way, I think I did an allergy rotation as an intern, and then I started putting everyone on fexofenadine.
Doesn't cross the blood.
Why is he on steroids? Great. I think that was one of those things that was left on there from an ED visit for shoulder pain. Yeah. All right. So he's not on a statin. What do we do next? Can we just biopsy? I'll tell you, this was my thought process. I will be vulnerable for everyone. So this is my thoughts. He had an elevated CPA with chronic bilateral forearm and calf cramping. Don't worry about the forearms. It's unclear. He's not on a statin. He has no meds. He's not other systemic symptoms. He has no rash. He's got no hot. Said he was hot or sweaty, but he was always hot or sweaty. And his inflammatory markers were all normal, and his TSH was normal. Anyone have any other ideas what could be going on with this guy? Thanks, Victor. It only took me 2.5 years to get that far, so bits and pieces. All right, so this is another diagnosis that orthopedics was able to make for me at the U. So this man got referred to orthopedics at the U for a pronator release, and in the process of his pronator release workup, I actually don't know what a pronator release is, but it's basically he had exertional symptoms when he was like flexing his forearm. Ortho wrote this wonderful HPI in which he says he has extreme pressure in both of his legs. He gets cramping and his pressure symptoms are worse with any activity, and it takes 30 to 40 minutes following activity to notice improvement, and 5 minutes to start having symptoms. So very, very reproducible. Circumferential on both legs, worse anteriorly and laterally, bilaterally. What does that sound like?
I'm just interested, laterally, bilaterally.
Does it sort of sound like they're describing the compartments of the leg?
Yeah.
Does. Do those symptoms sound somewhat similar to the person that we just talked about? If they were not found on the ground? Maybe. So ortho does compartment pressures pre and post exercise. So this is pre-exercise. His compartment pressures were all in the 30s, which is already too high. Normal is 0 to 8. So his compartment pressures are all too high pre-exercise. They also get post-exercise pressures as well. And his post-exercise pressures are in the hundreds and 75s. And he says his legs feel hard as a rock after doing 6 minutes of treadmill exercise. So this man ends up having something called exertional compartment syndrome, a disease that I had never heard about until my third year of residency. So what is exertional compartment syndrome? It's a reversible compartment syndrome triggered by physical activity. Basically, it's the exact same symptoms as compartment syndrome, but when you stop exercising, it gets better. It's basically like the angina of compartment syndrome. It's a way to think about it. So why? No one really knows, but they think it's non-compliant fascia. And who gets it? So military personnel are higher risk, older people, endurance athletes, so runners, and then the team sports that it's most described in are like soccer, lacrosse, and field hockey. So all sports where you would presumably need more lower body strength. And it's most common in the lower extremities. So you diagnose it with a pre-exercise pressure and then a 1 minute or 5 minute post-exercise pressure. So interestingly enough, of course, the U is good at a lot of stuff, but the U is a like exertional compartment syndrome center of excellence, I believe. And so I think we diagnosed more of this at the U allegedly than other places.
Is that going on with his upper?
Yeah, so it was going on with his upper extremities as well too. So he ended up having exertional compartment syndrome of his forearms and his legs bilaterally. And how do you guys think we treat this? Yeah, so this gentleman also got 4 compartment fasciotomies. And so here's his op note. He gets 4 compartment fasciotomies on both his left and his right legs. And then they actually took a biopsy as well, to Victor's point, because we weren't sure if this was a myositis, and he had viable skeletal muscle with absolutely no abnormality. Interestingly enough, there's like some data that these people's body habitus plays a role in like how much muscle mass you have. So this was this gentleman's x-rays that were taken like for a completely unrelated problem. But what do you notice about his calf muscle? Yeah, so this gentleman had a very This gentleman had a very large calf muscle, and so that probably played a role if he had non-compliant fascia or something else. But that is a disease that I was previously unaware of. So for the primary care doctors out there, if your patients have a negative claudication workup, they've got the right habitus, they're very, very active, maybe consider exertional compartment syndrome as a treatable entity.
You can also get acute compartment syndrome, which is snowboard boots.
Interesting.
Yeah, none of that.
Is the treatment just to take off the boot?
You can wind it even tighter. See better.
Thanks, Jake. All right, so today's conference, we talked all about compartment syndrome. We talked about found down compartment syndrome and exertional reversible compartment syndrome. So please, if you see compartment syndrome out there, let me know. Thanks, everyone.